Good afternoon. I'm David Holtgrave, the Dean of the School of Public Health at the University at Albany and the State University of New York. It's really a pleasure to get a chance to welcome you to this very special seminar that we have today. First, I'd like to thank Ann Hughes and Aaron Murata for bringing us all together today and arranging our event. Also, I'd like to give a very sincere thanks to William P. Kelly. Bill Kelly graduated from the School of Public Health with an MPH in 1995 and has been a great partner with the school, and his generosity has made possible this lecture series of very distinguished speakers. And so, Bill, we're extremely grateful to you. Thank you very much. And now it's my tremendous pleasure to get a chance to introduce to you Professor Dolores Albarracín. Professor Albarracín is from the University of Illinois, is an Argentine-American psychologist who studies social cognition, communication, misinformation, and behavioral change. She's a fellow of APA, APS, and SESP, and is the outgoing editor-in-chief of Psychological Bulletin. And as you all know, that's a tremendously important journal in the behavioral and social sciences. Her research is about 180 publications, including 5 books, and has been recognized with an award for outstanding mid-career contributions to the Psychology of Attitudes and Social Influence in 2018, and with the Diener Award for outstanding mid-career contributions in social psychology just this year. And that's from the Society of Social and Personality Psychology. She's also been the recipient of the 2019 Avant Garde Award from the National Institutes of Drug Abuse and is currently funded by the National Institutes of Health and the National Science Foundation. She uses a variety of methods, including experiments, surveys, meta-analyses, and big data in her research. And I just want to also say that personally, it's been an honor and a privilege to get to work with Professor Albarracín on a number of grants and projects and papers. And every one of these projects, I learned something new from her vision, from her wisdom, and really her redefinition of how we think about how social media and infectious diseases come together in public health. So without further ado, let me stop there and turn the virtual podium over and welcome Professor Dolores Albarracín.
Thank you, David, for that extremely warm and undeserved introduction. I want to thank you for the invitation, and also Erin and Anne for organizing, and of course to the generous philanthropist behind this series. Let me see if I can, yeah, I can move through the slides. That's great. And what I would like to do today is share what we've been doing in this domain for a number of years from an interdisciplinary point of view, beginning with the fact and sort of the commonplace that digital data come in very high volumes. We have 44 zettabytes of digital data, and every minute Americans use around 5 million gigabytes of internet data, which include 188 million emails that we send, including also 18 million texts and some 5 million Google searches every minute of the day. So the social media data and other forms of internet data, such as Google searches, truly qualify under the 3V definition of big data as data that involve high volume, high variety, and high velocity. So we have a really big text out there. You encounter this text every day. And this is of great interest to the social and behavioral sciences naturally, because it is some of the easiest to process information, most expressive information, and most frequently exchanged information by human beings. This text, like every other text, says a lot about who produced it, So it gives us access to the author's inner life through both intentional productions as well as less conscious productions in the language. And it also says a lot about the region in which it was produced. So fortunately, we have natural language processing techniques to actually code it. So we don't have to go through zettabytes of data manually, but rather we can replace the old manual counts or forms of manual coding, especially with automated counts or automated forms of coding via machine learning and artificial intelligence methods, which are right now widely available and improving every day. So the data, along with the methods, have really given us a lens to predict, understand, and potentially change health outcomes. And that's what I'd like to share today. First, beginning by how we can use these social communications to predict something like new HIV diagnosis or the top causes of mortality in the US. And then I will move through other problems related to these predictions and what they actually mean, and move to other uses of the data for understanding and potentially for change. So in this talk, I have 4 questions. The first one is, can we predict epidemiological patterns? And if so, why? Question 2, can we understand the beliefs, attitudes, or intentions or behaviors of a population? Question 3, can we understand message or policy impact by analyzing the language in social media? And question 4, can we use similar methods to produce changes in a population or to produce at least ways of intervening that rely on these methods? So the data I'll share with you are on various issues. I've primarily studied HIV, but for this talk and along, over many years, I've studied other issues as well. But this talk involves HIV also, as I said, the top causes of mortality and also vaccination. And I will rely on Twitter and Google Trend data. Throughout the talk, you'll get to see both. Don't you love this Twitter icon? So the first question, can we predict HIV and sexually transmitted infection cases, rates in the US? We have these county level data for HIV and sexually transmitted infections such as chlamydia or gonorrhea. We have been continuously crawling the random Twitter API, the so-called garden hose, which not anymore, but in the past could be geolocated for free. Now you have to pay for a special API. But it was really a tremendous data source of geolocatable data, which we used. So the process for all the research, and I'm sure you've encountered how this goes from other projects, you parse the messages, tokenize the language to be able to analyze it. Then we geolocate for this project to the county. And then we group the tweets as documents representing each county in the US. And from that, we do a topic extraction, which is an analysis in which we find co-occurring words. And for those of you who are familiar with especially psychological methods of data analysis or educational methods, this is very much like an exploratory factor analysis. And you end up with your topics, and these topics have a probability for each county, and within a topic, you have probabilities for the words that form the topic. For each county, we also have the new HIV cases, gonorrhea, and chlamydia rates. We used 4 years of data. We have the tweets for each county, have been developed and processed, and therefore we can predict A, the rates, from B, the Twitter topics. And we can obtain a correlation between the rates as predicted by the Twitter topics and the actual HIV rates for a county. So we had multiple years of data, and these are the correlations between the predicted and actual rates. And the reason you're seeing these little triangles is that, it's an entire little correlation matrix, because you have predicted rates and actual rates for multiple years. But the diagonal, if we start there, shows you that the predicted rate for HIV based on Twitter and the actual HIV rates correlate 0.57 for 2009, 0.58 for 2010, 0.45 for 2011, and 0.61 for 2012. You could also do other experiments like say, well, I want to know if what was predicted in 2009, is it still good, and does it correlate equally highly with the rates in 2011? And no, in that case, it's lower, but for other years, it's okay. So you can use this to ask other questions if you want. But the primary question here is on the matrix diagonal, which is the language for that year correlated with the rates for that same year. For chlamydia, you can see that these correlations are a little bit weaker. And for gonorrhea, you can see that they mirror the HIV predictions quite well. So this is, one answer then, and you can then map it and see, well, how do things look? And of course, when you map them to the naked eye, they look tremendous, better than the actual correlations, but you have to keep in mind that the correlations are moderate. They are not extraordinarily high. However, here you can look at the actual rates for California in 2013 on the left, and the actual the predicted rates in 2013 on the right. So you have the left are the CDC reported rates, and the right are what we calculate from Twitter. And the maps look quite nice, actually. So we have some answers, such as, can we predict regional epidemiology? And yes, we can. We can in the HIV area. It's been done in other areas like heart disease. But of course, for those of you who are wondering, well, but why? And first, what does it mean? And is it adding over and above other factors that could be used to predict epidemiology as well? And I think that is actually a key question, and as a behavioral and social scientist, something that, of course, I wonder as well. What is in the Twitter signal? What does this mean? So one thing that it ought to mean is that the language depends on characteristics of the population, such as its socioeconomic status, the health behaviors people are doing, are they living in a city or urban area? So counties vary, and we saw it last week in the news displayed prominently how you can have a red state, and here is, a little blue county in Pittsburgh. So these factors are probably some of the factors that we are picking up through the Twitter analysis, the fact that the counties differ, and these differences have something to do with what people are saying or how they are saying it on Twitter. So that's what we wanted to test. to try to understand how language is actually a proxy for demographics, SES, health behaviors, and environmental conditions that actually also correlate with disease rates. So we did this with regional epidemiological data, of course, in this case, the top causes of mortality in the US, 2017 data, and regional tweets. In addition to regional data on SES, demographics, health behavior, and environmental factors. And this is ongoing. The first author is the fabulous Bida Fayyaz-Farkad, who is a health economist postdoc in my lab. And we analyzed the top 10 causes: heart disease, cancer, and now unfortunately we have a new one inserted there that we have to look at. But data that I'm sure a lot of you know very well, and some of you are probably studying some of these specific diseases. So we have these data. We extracted the data from the CDC Wonder database. And we had, again, geotagged Twitter data aggregated by county for a 10-year period. So this time we used the topics that were pre-specified by Schwartz et al. In a study of Facebook, which have some nice properties. So we use these pre-specified topics to do the analysis. And we also obtained factors that are related to, for instance, social health disparities that account for differences across counties. So data from the American Community Survey, area health resource files, data from CDC to be able to know, well, what is in this mix of the language. Is it education or race? Is it poverty? How is air pollution being reflected, or patterns of health behavior like inactivity and outcomes like obesity? So we used, big data techniques to actually fit 3 equations. First, we predicted mortality from Twitter topics. Of those 2,000, those that had variance across counties were used. We also then run another model predicting mortality from county characteristics, and a third model that includes both the Twitter topics and the county characteristics. So the first equation, which you have, and again, I'm going to show you correlations between predicted and actual rates. So the correlations between predicted and actual rates, which were done for 10 different years with 2 different regression methods, which is why you have these confidence intervals, because it's the summary of many models that we fit for each year with 2 methods, converged to show that, as we know from the previous slides that you saw, and there is at least an analysis of heart disease predicted from Twitter. Yes, you can use Twitter to predict all of these diseases with, some adequacy, like, correlation of 0.4, 0.5, 0.6. These are great for social and behavioral science if you think, well, who knew that Twitter had so much in it? But of course, if you're trying to really predict, you would want something better than this. I am well aware of that. But this is, in any case, the prediction that you get from Twitter only. If you use all of the controls, that is, SES, demographics, inactivity, obesity, and environmental factors, you get better predictions, however. So something like heart disease and cancer is very well predicted by all these other factors. And there is variability here, but the most important question is, well, let's say I have all of this in. Is Twitter adding anything? And the other important question is, well, what is going on with these predictors when you have Twitter, and with Twitter when you include these? So this includes all three bars. So Twitter only, all the SES, structural factors, health behavior, the so-called controls here in gray. And then you have both. And as you can see, once you have all of these controls, Twitter doesn't add a lot, which essentially implies that what Twitter is picking up is these demographic and health behavior differences, which of course validates everything we know about health and provides a sense of the internal validity of the predictions. We didn't find anything with this, it would be a problem. But it also says that Twitter is not adding necessarily over and above here. And I'm not saying that this is always the case, but I would argue that this is probably most generally the case. So if you look at the actual regression weights in a separate analysis, we wanted to sort of be able to decompose these factors, the structural factors, what is going on with Twitter. So this is just a multiple regression with predicted rates from Twitter and all the demographics. So as you can see, Twitter has here a positive significant association with accidents, but it's barely there, right? It's almost zero. What predicts accidents is median income and inactivity. This I didn't know, and other factors such as being young, which we know, which is a negative predictor. If you look at diabetes, Twitter has no influence here whatsoever once everything else is accounted for. So what we find here is the usual suspects: poverty, inactivity, obesity as the principal predictors of diabetes across counties. If you look at suicide, it's a similar story. Twitter no longer predicts suicide significantly, so that regression weight is essentially zero. And you have other predictors. For instance, if you are insured, you're less likely to die of suicide, and if you're poor, you're more likely to die of suicide. So that's, I think, interesting to see and contextualize what this language is saying and what it's reflecting. Clearly, it is reflecting a lot of these other factors, and it's no longer explaining variance once these factors are accounted for. So in summary, the answer to question 1, can we predict patterns? Yes, we can. We can predict up to 35% of the variance in HIV or STIs and top causes of mortality. But this prediction is due to well-established regional differences in demographic, SES, health behaviors, and environmental factors. So question 2 is, how about measuring beliefs, attitudes, and intentions via social media? And you could imagine that this would be ideal because it's language, and beliefs, attitudes, and intentions are expressed via language. It's not like HIV, which is diagnosed very differently, right? So by beliefs, I mean the probability of an event or outcome, or knowledge, for instance, of disease prevention methods. Do I believe that wearing a mask will prevent transmission of the novel coronavirus? Attitudes. The evaluations of a behavior or policy. Do I support funding for X policy that affects health? Or do I have a positive evaluation of wearing a mask? And also intentions, that is a will to perform a behavior. Typically in our case, it would be a screening or prevention behavior. So to answer this question, you can take a look at our work in which we've used survey measures of beliefs, knowledge, attitudes, intentions, and behaviors during the 2016 Zika outbreak. So we had, in this case, 33 waves of data from February through August, with some 30,000 participants. They were all independent samples, just waves. And this was a probability phone survey conducted by the Annenberg Public Policy Center, with which we collaborate. So we had also 33 weeks of Twitter data mapped to counties. So in this case, we actually selected the tweets with keywords first. So we wanted a more relevant Zika relevant set, and then we modeled the topics across weeks. And we then correlated those topics with measures of beliefs and knowledge or intention. So for instance, the measure of beliefs was, how do scientists think someone can get the Zika virus? By sitting next to someone who has it, or by being bitten by a mosquito that has already bitten someone who has the virus. So we had beliefs and knowledge measures. We also had measures of policy attitudes. So if there were cases of people getting infected with the Zika virus in your city or town, would you approve or disapprove of special spraying at the ground level against mosquitoes to prevent the spread of the virus? And would you approve or disapprove of special spraying? Well, this is the same, but the second was a different policy. And we also measured the intentions to get a vaccine once the vaccine became available. So very much what we're seeing now in the pandemic, similar problems, except that outbreak was very well controlled and relatively minor in the end. We also measured preventive behaviors, as you know, via self-reports in the past 3 months. What have you done to protect yourself from getting the virus? And it would be things like wearing repellents or long sleeve shirts, and making sure there's no stagnant water in your backyard, and so on. So we obtained topics again from that pre-selected set of tweets that had Zika keywords. And then we wanted to correlate those topics with the survey measures over those 33 weeks to see, is this language on Twitter reflecting the changes in the public opinion or behaviors related to the Zika outbreak. So we found correlations. There were positive correlations for 3 topics related to beliefs and knowledge. So one topic that was related to microcephaly, of course, one of the principal outcomes of infection, Congress funding for emergency measures. So you can get a sense of what the topics might be saying. If you look at Congress funding, that's our own label for it. And you have words like emergency, CDC, Congress, Zika, and so on. And a third topic that we labeled as Zika protection and travel, because travel was, of course, a really important issue if, for instance, you were pregnant. So moderate positive correlations with these topics over time. We also found strong correlations with 2 topics for attitudes. So support for policies related to Zika prevention and the regional level correlated with a topic that's related to Congress funding and another related to Zika protection and travel. There was a topic that correlated negatively with vaccination intentions. And this topic is the language in it reflects some perceived threat that, the technology in blood transfusion and vaccines might be problematic. So this correlated negatively when it appeared over the weeks. And we also obtained positive correlations with prevented behaviors. So overall, like we saw for disease rates, we can now see associations between the language and what people think, which is a much more direct association, of course, and much more meaningful in a way, because people are probably discussing Zika online much more. They are discussing HIV or gonorrhea, and it was in the news, etc. So summary question 2. Can we understand the beliefs, attitudes, and intentions of the populations? Yes, we can actually predict up to 77% of the variance of attitudes over time. It's, I think, important to have an answer to that. It's the third question is, can we understand message impact? So, for instance, can we use social media data to understand message impact when you're trying to see if misinformation online might influence attitudes down the line? So that is one of the questions that we ourselves had. What's the association between social media messages and attitudes and behaviors in the area of vaccines? So we all hear regularly that a lot of the problems when the measles outbreaks, for instance, are related to rejection of the MMR vaccine because of these groups that are promoting anti-vaccination attitudes online. And there were some data, and this might be the case, but typically the data look like something like this. You have people who have anti-vax attitudes hanging out in these groups that oppose vaccines, and of course you don't know which one was first. So we wanted to improve the methods a bit to be able to look at this in slightly more detail. And the type of anti-vax misinformation that's out there has, of course, exploded during the COVID-19 pandemic. So if we were to look today, we would probably have a lot richer data on very elaborate conspiracies. So we had a study, a longitudinal study of the 2018-2019 flu season with also Twitter data, and the survey, which had 3,000 participants surveyed via phone. We knew their counties, and they reported their attitudes, whether or not they had gotten the flu shot, and whether they had discussed the flu shot with family and friends, and multiple times during the season. So we wanted to know and link these participants for whom we had individual level survey data with their counties for which we had Twitter data or geolocatable Twitter data. So to take you through the survey measures, we had a measure of vaccination. Have you gotten a flu vaccine this season or not? We had attitude measures based on what you know. How positive or negative do you feel about the flu shot? And also discussions in the past month. How frequently have you discussed the flu vaccine with friends and family? And with respect to discussions, it was important for us to see how the online misinformation that we wanted to analyze played vis-a-vis the discussions they might be having with their own family, assuming that perhaps when they discuss with their families might actually correct for the misconceptions they are reading online. So the process was very similar. These were pre-selected to be tweets related to the flu vaccine specifically, and we estimated topics, some of the topics, and some of these topics were ended up correlating with the survey measures. So the analysis was such that the topics are on the county level, people live within a county, and they are observed over time. So that's the connection. And we could then take exposure, let's say, to this topic in October and see how that affects vaccination down the line, or how it doesn't affect vaccination. So these are associations between a topic that we label vaccine fraud and children, so something that was available across counties and that varied across counties in October, November, that is during wave 2, and how that was associated with attitudes in blue and actual vaccination in red in November, February, March, and April. And as you can see, the the stronger effect, which is still not very strong, is the effect of that kind of misinformation topic in October, November, having an association with attitudes and vaccination, but a negative association in February, March, and April, implying that the misinformation that you got in October and November sort of stayed there and incubated, but we observed the influence a little bit later down the line. However, these effects, which are rather weak, are only present when people are not having discussions with friends or family. When they are having these discussions, the effect is pretty much gone. So this is, I think, an interesting avenue for intervention in terms of getting people to have more open discussions about all these issues rather than avoiding sensitive topics, which is often the tendency, because the discussions in real life seem to be eliminating whatever effect the online misinformation might be having. So in summary, linking regional tweets to individual level responses had some lessons for us. First, the effect sizes are much smaller than the aggregated regional ones. And this is not a huge surprise given what we know from aggregation, but it's certainly a cautionary note in terms of trying to move from aggregated data to individual level data, which of course are not always available, but sometimes they are. 2, it suggests that there is a prospective impact of vaccination misinformation, or possibly there is, on vaccine attitudes and actual vaccination. So that is one aspect relative to question 3, which is, can we use the data to understand message impact? The next part is, can we use the data to understand the effects of policies? And here I'm going to show you a little bit of data from a project that is served in 2 papers, one that just got accepted, but it's under embargo. And I'm going to share all the papers with Erin for those of you who want more details about the analysis. So it's analysis of the impact of the Affordable Care Act, and also I'm going to show you some analysis with Google Trends. So we analyzed the effects of the Affordable Care Act, comparing HIV diagnosis and PrEP units reimbursed by Medicaid before and after the expansions, comparing across states that had expanded and not expanded, with a difference in differences approach. So you have the map here, the non-expanded are the dark blue states, as you know. So we looked at these effects, and you can see here, these are not social media analyses, these are effects on HIV diagnosis. So the effects of the expansions, post-expansion, on the ability to diagnose HIV that was presumably undiagnosed because of lack of healthcare access. And as you can see, there is an effect immediately after the expansion, suggesting that there were, large groups of people who had no access, but as long as they had insurance, they could get an HIV test and hopefully get treated as well. But that effect goes away. We also see effects on the number of PrEP units reimbursed by Medicaid, and this effect is more stable over the years. So it's not just that the undiagnosed got diagnosed, but rather, people are continuously being enrolled once they have access to health insurance. And this is the pattern that we also looked at with respect to social media data. That is, what we're seeing here, would it be reflected in something like Google searches, which are excellent to analyze trajectories over time. So we looked at searches for Truvada. This was also done by Bida Fayaz Farkad, and she looked at the effect of the ACA on Google Trends for Truvada, and as you can see, the effect is very similar to the effect on actual prescription of or reimbursement of PrEP units by Medicaid. So in summary, we see effects of the ACA, a 19% increase in HIV diagnoses, and also an increase in numbers of PrEP units reimbursed by Medicaid. But for the sake of our talk, our presentation, what we see here is a parallel increase in interest in Truvada through Google Trends. The third question, or then, can we understand message or policy impact? Yes, I think the data are certainly useful for that and can provide ways of validating other data or also insights onto what's going on in people's head when we also have objective data without any insights onto the human perspective, let's say. The fourth question, though, which is, I think, the real challenge, is can we use social media data and especially big data methods? Because of course, we can use social media or we can use Zoom for lots of things, but can we use big data methods to change behavior or obtain clinical outcomes? This, I think, is a real challenge, especially for the social media data. This might be similar in other domains of big data, but it is, I think, a fundamental problem for us. And this is something that we've looked at and are looking at actively in two projects. One is a project for men who have sex with men, trying to mine social media messages for HIV testing and prevention. So can we use these methods to mine optimal messages and thus be able to reuse what's sitting out there and what has been produced by living communities in their own words and today or tomorrow? And can we then reuse those messages that we mine through these methods? That's what we want to do in this project, and also the NIDA Avant Garde project has a bit of this, but it's more of a community creation. So in this project, in which David is the co-I, we have a triangulation of three sources of data. We are looking at epidemiological data on HIV, so HIV prevalence and the county level. We have behavioral data collected by our Emory colleagues, especially Travis Sanchez, who is the most involved in this particular project. So we're using the AMIS survey, the American Men's Internet Survey, to estimate the behaviors on the county level. So are the men using PrEP? Are they testing frequently and so on? And we also have big data methods to know what is going on social media in these counties. So we have these three pieces of information which can tell us, well, is the county a county at risk? Is there high prevalence? Are there enough men who have sex with men in the county? Do they need to increase their PrEP use? And if they do, are there messages on PrEP for that county, or is there a gap between the behavioral or service need and the messaging environment? That is the process. And then, assuming we find gaps, and I'm sure I don't have to convince you that we have found gaps, then we can mine messages on testing PrEP or condom use that are MSM appropriate and classify messages that have characteristics that we want. And in this case, we wanted the messages to be both MSM appropriate and also actionable. So telling people what to do about a problem, not just information about what PrEP might do, but where can I get PrEP, go get PrEP, that kind of message. So we're using these big data methods to now mine messages rather than make predictions, and then be able to disseminate those messages strategically to the counties. So we might select messages. This is Twitter and Instagram. So you might find messages that are ideal for various reasons, and also find vulnerable counties with high numbers of MSM, high HIV prevalence, find the gaps, like I said, compare the behavioral service needs and social media messages to find the gaps, and then send the mined messages to these counties that need, for instance, PrEP messages. And then we have a field experiment to test the selection of the messages. And this is done through an app, which I have a little video. If I can play this, this is for health departments to use. So the rest is more just instructions, because this is being sent to the health departments or community agencies that are going to test the app for dissemination of the messages. Okay, there. So we are getting ready to conduct this experiment with experimental weeks and control weeks. In the experimental weeks, we will use this message of mining the messages through these methods to find MSM appropriate and actionable messages to fill specific county level gaps. And then we also have control weeks in which we simply send a random selection of HIV relevant messages. And we're tracking how these messages behave in terms of disseminations, likes, and outcomes. So we're still a little bit removed from actual impact on behavior, but it will be a way of testing if the methods have promise in terms of finding ways of intervening better. So in conclusion, we see that social media can be used for regional prediction of diseases, like our data and many other projects have shown by now. And also that the regional predictions are explained by regional differences in SES, health behavior, and environmental factors. This is something that is often ignored or minimized because people control for one factor and say, well, Twitter still predicts, but when you're really trying to be exhaustive, I think you will find it doesn't predict over and above these factors. We also see that social media data can be used to understand the effects of messages and also the effects of some policies. And this is a really important avenue for future work. And the challenge, though, is using big data methods for change. So using the hallmarks of automation, automatic dissemination, speed, efficiency, low cost, and also involving communities in disseminating the messages. Thank you.
So wonderful presentation, Dr. Albarracín. I really appreciate it very much. And we have questions already coming in from the Q&A function. And let me invite all of the participants today. Please feel free to use the Q&A function to add in your questions. That would be great. So the first one is from Bill Kelly, and that is, the question is, often, and this was submitted, Dolores, when you were on the first question, when you were about 12:20, when you were on the first topic area, that often the action or intervention needs to be very local to be practical. How do you suggest we move from bigger to smaller, such as census block, original, or individual? Or is that a separate kind of study or a separate kind of activity? So it's sort of a scale of intervention question.
Yes. No, I think that's a great question, and the only reason we're not doing those initial analyses and the zip code level is that something like HIV is not easy to obtain at that level because of the suppression laws. But I think the finer the grain, the better, and that might also provide a better solution for the aggregation problem, to at least aggregate at a smaller level. So absolutely, I think if you have the data at a finer scale, like neighborhood and so on, it works in the same way. We've done it at a local level, let's say for the city of Philadelphia, but we've typically encounter more data suppression issues when going to those levels, and certainly for the whole country it wasn't available for us. But if you have direct access to the data, I think yes, that's the way to go. Absolutely.
Great. No, thank you very much. So the second question from Abby is, did your Twitter analysis compare the change from 180 characters to 300 characters in Twitter, or did your research focus on the original character limits?
No, we never compared this aspect, so I couldn't tell you if it has made a difference or not. I would say, on the one hand, it's a really interesting question, and you could see there is just more information, more language, more human stuff being communicated when you have more characters. At the same time, based on the analysis of many years of mortality data and those confidence intervals being small, I think it hasn't changed things dramatically. Probably because people are using a lot of the extra characters for hyperlinks and hashtags and at David Holgrave types of things.
Oh, that's great. No, thank you very much. And again, I'll invite people to use the Q&A function. If I could take the liberty of asking a question, we've had many conversations about this line of work, but one of the things that struck me during your talk today was I was thinking about the role of kind of the Twitter algorithm, for lack of a better word for it, that, you kind of, as you're tweeting, you're kind of getting back generally messages that are consistent with what you're interested in, and people who have different kind of points of view are sometimes moved away, although depending on what you tweet about, one can certainly get a lot of differing points of view as well. But I was trying to think about kind of this mysterious and invisible actor of the Twitter algorithm that's kind of clustering messages together and how that might impact the results. And I just was curious what your thoughts were.
Yes, I think that's a great question. I don't know how it's having an impact, but it should have an impact if we are assuming that what we're seeing is influences from Twitter to behavior.
Mm-hmm.
Often, however, what we seem to be capturing is more like the temperature of a phenomenon in the population, right? And not necessarily the influence of the media themselves, which is why a lot of what we capture in the prediction part, at least, is related to SES and demographic or health behavior characteristics. When it comes to the influence of misinformation on social media, though, it is interesting to see that just the presence of the content on social media is having a potential influence on individuals. And that implies that this is reflecting the general conversation in the community in real life, more than being circumscribed to the language on Twitter itself.
Sure. Oh, thank you. No, that's great. And, I think if I can ask another question, I know given who registered for this meeting, we had some people from across the US, but we also had a number of faculty, staff, and students from University at Albany that signed up today. And I wondered if students are interested in doing work in this area, given you started out with very impressive statistics for how big the data sets were that you were analyzing and so on. Do you have guidance for graduate students who might be thinking about doing work in this area? How does one get started, and what pathways does one pursue?
Yes, I think you have to look at this like any other method of data analysis. So getting solid training and the data analysis, even the traditional statistical point of view, is helpful. And I'm not a statistician. I'm just a psychologist who uses these methods. So that general background, plus you certainly need to be, you're probably all using R already. Anything that has been shown here, more or less, can be done in R. Python is very helpful also for the data manipulation part. So taking some programming classes, I think, is essentially, and then like for everything, just keeping your brain on, because these data have the same problems like any other data that you're looking at. So the same processes of statistical inferences in theory, I think, apply, but concretely, probably programming, I think.
That's great. And I'll just ask the last question, and then I know we're about out of time, is the line of research. It's so well organized and so paradigmatic. You're bringing a certain paradigm and a certain theoretical approach to your whole line of work. And just when you think about, the next 3 to 5 years, not to give away any trade secrets, but anything sort of major on the horizon that you'd like to just mention as well too, Dolores?
Well, I mean, from a methods point of view, I think we need to write a paper comparing what you get with aggregated and individual level data, because you know, there are some major differences, so to keep in mind the ecological fallacy and so on. But perhaps the most exciting project in which you're also involved is the Avant Garde, which is building a community for the Appalachian and Midwestern regions affected by rural opioids, and using these methods in part to communicate with the communities, but at the same time building a platform through which they can communicate with each other and inform citizens of appropriate policies for opioids, and hopefully help to curb the epidemic, but especially the impact on HIV and HCV.
No, terrific. Thank you very much. And
Thank you.
I know that we're out of time. I just wanted to, I know if we were all in the same place, there would be a round of applause and an ovation. And I just want everyone to please join me in sincerely thanking Professor Albarracín for today's wonderful talk, for the discussion, and for bringing us this really pioneering line of research. We really appreciated and benefited from your time today. So thank you very much.
Thank you. It's an honor to be here.
Great. Thank you. Thanks to everyone for joining us. Bye-bye.
Thank you.